Hi guys, if you arrived at this video lecture, that's great, as you are on the right way. We're going to discuss in this video abdominal compartment syndrome, and if you are a medical practitioner, you'll see at least one patient in your medical practice with abdominal compartment syndrome. Compartment syndrome, and especially abdominal one, means that there is increasing pressure inside the cavity, and there are many changes like going of fluids, electrolytes from one side with increased pressure to another one, and migration or spreading of these components, and increasing in size of cells, for example, and compromising vessels, and of course producing devastating and abnormal function of organs and tissues. By other definition, compartment syndrome occurs when pressure is increased within a fixed cavity of the body and leading to ischemia, muscle damage, and organ dysfunction. And adverse physiological consequences of elevated intra-abdominal pressure are oliguria, increased airway pressures, and reduced cardiac output. Pathophysiology, of course, increased abdominal pressure, as we are discussing abdominal compartment syndrome, which affect venous return with decreased cardiac output, decreased stroke volume, low cardiac output, a low return of blood to the heart, low stroke volume, increased systemic vascular resistance, and decreased oxygen delivery. At other side, we will have a patient with kidney compression because of decreased renal blood flow, no urine producing, and no urine output or low one. And in intrathoracic pressures increases because intra-abdominal cavity will press up. If this one is abdomen and thorax, this one will push up diaphragm and will compromise airways with decreasing compliance, with increasing airway pressures, hypoxemia, increased pulmonary artery pressures, and increased central venous pressure readings. Possible causes of raised intra-abdominal pressures, or intra-abdominal pressure to be correct, can be divided in retroperitoneal and intraperitoneal. You see retroperitoneal like edema in necrotizing pancreatitis, hematoma, pelvic or retroperitoneal, bleeding after aortic surgery, and edema related to resuscitation. And intraperitoneal one, hemorrhage, visceral edema, abdominal packing, bowel dilatation, mesenteric venous obstruction, and pneumoperitoneum. Acute ascites as well. Which patients are at risk or high risk of abdominal compartment syndrome? So patients after major trauma, damage control surgery, or very traumatic surgery, laparotomy for bleeding ischemia, oral laparotomy for postoperative complications, or very decompensated patients, and massive volume resuscitation. Clinical features are elevated intra-abdominal pressure, abdominal distension from high volumes, and consequent organ dysfunction or multiple organ dysfunction or MODS. Importance: decompression can reverse abnormal physiology, but probably could be fatal progression if left untreated. Measurement of intra-abdominal pressure can be done in two ways, like indirect methods or direct one. So indirect assessment of intra-abdominal pressure by bladder, intravesicular Foley, a catheter insertion, and through the tube, a special tube which is fixed at the at the symphysis pubis, and up if we are measuring by centimeters of water, and increase column of water and we see which pressure is, or if you are measuring with manometer that reading right at the symphysis pubis, we are inserting 50 to 100 milliliter of saline solution into the bladder that have to come out and rise in our tubes or make a pressure on manometer. These measurements are not so invasive, as you are only applying to the channel Foley catheter, and it can be removed easily. In times that direct methods include measurement of intra-abdominal pressure by using transducers like a Ver's needle during laparoscopic surgery, and another one is peritoneal dialysis catheter. But direct methods are invasive. And grade, here you see a classification with a table of grades from 1 to 4, and you see different pressures, and pressure more than 12 or more than 10 even is considered increased, or grade 1 intra-abdominal pressure. No signs, and maintain normovolemia. The treatment is at grade 2 you see 16 to 25, and equivalent in water is like 21 to 34 centimeters of column of water. And you see some signs of increased pulmonary artery wedge pressure and oliguria, and volume resuscitation is the likely treatment. At grade 3 you see 26 or 35 millimeters of mercury if it is measured by manometer, and 35 to 48 if it is measured by column of water or column of the solution that is introduced. Normal solution or water usually. Anuria, decreased cardiac output, and increased pulmonary artery wedge pressure. You should consider at this grade decompression of the abdomen to prevent some complications like ischemia, oliguria, and organ dysfunction. And grade 4, which is higher, more than 35 millimeters of mercury and more than 48 equivalent in centimeters of water. Anuria, decreased cardiac output, of course, and increased pulmonary artery wedge pressure, which is more severe at this time, and decompression is mandatory. Renal effects like intra-abdominal pressure 15 to 20 millimeters of mercury. Renal blood flow and glomerular filtration will be affected with the following effect like anuria. And stenting of the artery will not help, as there is pressure increased one that affect flow of the blood through the renal artery. Parenchymal compression and renal vascular resistance. It is reversible but only by decompression. Gut and hepatic effect, decrease in blood flow. Ischemia is produced as more than 40 millimeters of mercury, and of course improve with decompression. If to be sincere, every organ in the abdomen will suffer: the gut, the the liver, renal, spleen, and everything will suffer from this compression and compromising the flux to the organs. Diagnosis can be done by CT scan with narrowing or collapse of inferior vena cava, direct renal compression, bilateral inguinal herniation, from intra-abdominal pressure very high, and of course organs like gut will find a weak side like umbilical side, or herniation from umbilical side or inguinal one. Ball wall thickening, rounded abdomen, or increased in volume, splanchnic, hypoperfusion and acidosis, and abdominal perfusion pressure. And here you see effect of intra-abdominal hypertension. Why this does occur? Because body trying to compensate as hypoperfusion of the organs is done, and they're trying to pump more blood by increasing pressure through these constricted vessels. Cardiovascular effects like decreasing venous return by compression of inferior vena cava and portal vein, increased intrathoracic pressure by decreasing lung volume and compliance, cardiac contractility and cardiac output become low because return is low and heart don't have what to pump, or have a low quantity that comes from inferior and superior vena cava, especially from inferior vena cava, because not from upper, because vena cava lower going through the abdomen. Decreasing peripheral oxygen delivery at the respiratory level, elevation of diaphragm, as I said, decrease in thoracic volume and compliance, increase intrapleural pressure. Normally it should be decreased during inspiration. Increased airway pressure to maintain ventilation, and compressive atelectasis and ventilation perfusion mismatch, hypoxia and hypercarbia. Effects of intra-abdominal hypertension: central nervous system effects like impaired venous return and cerebral pooling, increased intracranial pressures. You have to do differential diagnosis with mesenteric ischemia, ruptured abdominal aortic aneurysm with full filling of the abdominal cavity with blood, and severe anemia, toxic megacolon, acute appendicitis, and acute diverticulitis. Treatment: non-surgical therapeutic options. You are inserting or placing nasogastric tube for gastric decompression, rectal tube placement for colonic decompression, percutaneous drainage of abscesses or abscess in ascites or fluid from the abdominal compartment. If patient have a ascite and neuromuscular blockade in an attempt to relax the abdominal muscles or abdominal musculature in ventilated intensive care unit patient. And emergency laparotomy if organ damage is noted and grades 3 to 4 of abdominal compartment syndrome do have to occur. Thank you very much and have a great time, guys.